Another busy morning ahead. We're starting off this morning with Helen Smith. Helen is an absolute saint because about 4 months ago, maybe a little bit longer than that, I was needing some help with somebody who was in distress, and by hook or by crook, several people gave me Helen's name. I phoned her, we chatted, she was very sweet and kind, and I thought, God, ask her. So I said, we're having a conference, would you come and speak? And without any hesitation at all, she said yes. She's here this morning, and just to tell you a little bit, she is consultant clinical psychologist of the small spinal cord injury centre at the Royal National Orthopaedic Hospital. Without further ado, here is Helen to speak to you now.
For those who know us better as Stanmore, it's the London Spinal Cord Injury Centre. Can you get your eyes to back? Yeah, I work part-time at the London Spinal Injury Centre, and I do some sessions for Spinal Injuries Association, SIA, which I'll refer to. I expect most of you know it. And we have Joy here somewhere from SIA. It's embarrassing. Doing telephone counselling as well, so that can be for people who are not London standing. So a proportion of the people I meet have transverse myelitis. Others have injuries, spinal cord injuries from accidents, assaults, falls, and other medical conditions. I don't have transverse myelitis myself or any physical disability, but I think some of my experiences in life have forced me to think about coping strategies, think about ways to deal with difficult feelings and stressful situations, which overlap with some of the patients I meet with spinal injury and their relatives. So the methods I use, and I'm still learning, of course, were determined not just by the situations I found myself in, but by the person I was and had always been, and the person I've become. So in this talk, I'm going to attempt 3 things. I'll give an outline of what a person with TM and their relatives have to cope with and the challenges they're up against, or you are up against. And second, I'll be talking about research, relevant research on coping, from psychologists in healthcare generally, because that's a bigger literature, and spinal injury specifically, but we won't get too technical today. And third, I'll give some ideas to help people cope with TM. This is relating to real people I've met, but not giving information that could identify them, of course. Okay, so thinking about the kind of sequence of challenges that people go through. Phase 1, you may remember, having been in bed, maybe on a ward, or being off sick, or being away from your usual activities. And there are lots of questions on your mind. Will I walk again? Will I work again? Will I have sex again? And for many families, just adjusting to the ward routines and visiting and being off sick is a huge challenge. And of course, there's often a drop in income as well. And being in the sick role, I don't know if you know the expression, the sick role, it means being in the position of being a sick person or a patient, a receiver of help, rather than all the roles that you normally fulfill, like parent, employee, and neighbour and friend, and so on. Being in the sick role can bring advantages as well as disadvantages, but it can take its toll on relationships. And the second phase is about the change, coming to terms, or not coming to terms, with a changed body. To have hope or not to have hope. We have a lot of patients at the moment who are struggling with this. You know, should I be walking again, or should I be forgetting all about walking? It's a hard one. Other people might be urging you to move on and accept a disability that they don't have. But moving on too fast might feel like a betrayal of who you were and all the things that you loved about your old life. Some of you may feel a need to grieve for what you've lost, many losses usually. But at the same time, you're having to take in all kinds of new information. This is what I think is special about people in the spinal injuries setting, is that they're being expected to learn. It's almost like they're at college, having to learn all kinds of stuff. At the same time, they're grieving, and that makes them different from patients in other medical settings. Phase 3 preparing for discharge, or Barbara, who some of you may have met yesterday, and she's going to be speaking shortly, she talks about a new normality. So preparing for a new kind of life, a new phase in your life. And you might find that things that were safe and familiar about the hospital ward or being in bed, those things seem very comfortable compared to suddenly having to face the neighbour from a wheelchair, perhaps, or having to move to a new home, as many have to do. And finally, there's your new life outside the hospital, which most of you are in now, and have been for a while, actually. Models of coping. Now, looking at the research on coping, there are all kinds of models which all conflict and are incredibly confusing, and I'm not going to attempt those, but the way I think about it is much simpler. I split it into two halves: problem-focused coping and emotion-focused coping. Okay. Now, problem-focused coping means coping with your practical problems. How to empty your bladder and bowels, how to obtain money, how to get from A to B, and so on. At the same time, you're having to deal with great surges of emotion, aren't you? Feelings of rage, feelings of hopelessness, fear, often anxiety. And sometimes I do workshops with staff when we think about this distinction, and it's important for relatives too. You need to be able to interpret the behaviour of the person with TN carefully and offer the right kind of support. So thinking about an example, suppose you have a man with TN and he's refusing to go to OT, for example. People might think, oh, he's just not coping, when actually he's using a coping strategy aimed at keeping his head. He knows that he could easily just lose it and break down in front of other people, and he really, really doesn't want to do that. So he avoids OT as a means of coping. So he's actually using emotion-focused coping, whereas the OT was hoping he would come along, try out a new wheelchair, be ever so grateful. She was hoping for some problem-focused coping. So you might find that you need to listen more to uncover what the person is really thinking and feeling, so that you can then offer appropriate coping strategies, as we call them, to add to their repertoire. Now, by repertoire, I mean a toolkit. I like this expression, I use it with my inpatient groups. A toolkit of coping skills, and we all have these. We build them up over time. Things we've learned from our parents, things we've discovered, things we've got from books. Some of our strategies are no longer possible, for example, going for a run if you're feeling frustrated and tense. Others are possible but not safe or ideal. For example, drinking a lot of alcohol when you're feeling sad is no longer an ideal solution for many people. So, think about how a toolkit contains lots of different tools. You wouldn't, for example, build an extension with just a hammer. You wouldn't cook a meal with just one utensil. So why should you have to cope with something as complex as TN using one strategy? Some people think stiff upper lip will get them through, or medication will get them through. Well, it's going to need more than that, isn't it? You're going to need to learn new coping skills to get the idea that you want. I should just mention, one of the coping strategies that we usually talk about in our discussion groups is assertiveness. Getting what you need, knowing what you're entitled to and getting what you need. People are often very reluctant to ask for help. They see that as a weakness. When actually living with a complex condition, having to get benefits, wheelchairs, appointments, you're going to have to be assertive, saying what you need and getting it. And SIA have a course called Your Voice, which is designed to meet that need. Now, thinking about research with spinal injured people, I've put these references up here in case people are looking for some reading, but I won't talk about all of them. These are just examples. We've got Karen Wally Hamill as an OT, wrote a lot about rehab, and she emphasises that it's not just about physical skills, but independence. There's too much emphasis, I think, on that. She reviewed qualitative studies and said professionals need to listen to the perspectives of people with spinal injury, and that what makes a big difference is the calibre and vision of the staff. The vision, people wanted a vision of a future life, even with their condition. They wanted to connect their past to their future. And that's where I think sometimes being in a medical setting, like a hospital or a clinic, can let people down. It's too much about what are your symptoms, have we sorted them out, and not enough about What are you going to be doing with all the hours that you've got now at your disposal? I was fascinated by the Stitch Links exhibition. They're talking a lot about activity, social interaction, as well as the physical benefit. There was a study combining large numbers of ex-patients from the US and the UK, the second one on the list there. They filled in questionnaires more than 20 years after their injury. This was men, they attached less importance to their work and their physical health at this stage in their lives, and they valued their relationships and the activities that they could attain. So they seem to have shifted their priorities and managed to achieve satisfaction with life, and it's quite an encouraging study. It makes you think humans can be adaptable, humans can grieve for what they've lost but find new satisfying quality of life. Then there was a study with women in 4 UK units, including ours, Victoria Samuel. She found from interviewing patients that there was a theme of feeling vulnerable, particularly in the ward, and there were factors which helped people to feel less vulnerable, like the way that staff spoke to them, and others that made it worse, like lack of dignity in the design of the ward. And there's a Swedish study talked about if you're involved in planning your own rehab and your own aftercare, and if you're given information, which I'll come back to later, and emotional support, these are crucial elements in the rehab. So it wasn't all about getting the right equipment or getting the right medication, it was about being involved and supported as well. And we had a study by one of my former trainees on our unit. He has spinal injury himself. He looked at informal peer support on the ward and found that patients got a lot from just interacting with others who are in the same boat. So I hope that a lot of you, by coming to this conference, have picked up, I can see nodding, tips and support from being with others. Now, a lot of these studies are using qualitative methods. That means a small number of people being interviewed in depth rather than a large survey with a questionnaire. The advantage is that themes come out which haven't been voiced before, whereas a questionnaire asks about the things that the researcher, who's often able-bodied, already knows something about. So I probably, if I'd been designing a questionnaire about women's experience, I might not have put, do you feel vulnerable? It hadn't occurred to me. Whereas by just interviewing and listening and drawing out the themes from the transcripts, she got this theme coming through loud and clear. So if any of you are invited to take part in qualitative research, I would say it's a good thing to do. Right, so what about I call these my top 5 ingredients for successful coping. This is based on my experience at the spinal injuries unit. The first one is information. What have I got? How will I manage it? This is the one that's so difficult in TM, isn't it? Working with a lot of other spinal injury people. And this is where a good consultant makes a huge difference. You want to know the answers, but where there are no answers, you want to know why, and you want to know when there might be better answers. And I think the consultants we've got at the moment are good at this. I'll say more about all of these in a minute, but the second one is time, of course, to grieve for your losses and to learn what you need to learn. The third is support, someone to listen without judging you, and to help you feel that you're still you, as Christopher Reeve said. Fourth, role models or heroes. Again, we have some here today, I'm sure. These are real people whom you find inspiring and who can teach you. And the last one is good times. This is often, I think, forgotten about as well in the medical setting. Is that you need to have fun, you need to have good times to make you feel your life is worth living again. And of course, these can apply to relatives as well. Now, I'm hoping this diagram may be helpful. If you look on the left, the patient or the person that you are, the injury or condition that you've got, and your family, your cultural factors, your beliefs and so on, all come together and influence the second box, which is your understanding, your appraisal of the threat and the resources. I think threat is quite a useful concept. It means, am I going to lose my job? Am I going to be disabled? Are my friends going to walk away? You face a lot of threats when you have a major health crisis. But you also have a lot of resources, and you may not realise some of the resources that you have got, some of the talents, knowledge, personal qualities that could be really useful. So you make this appraisal, and from that appraisal you come up with a list of things that you're going to have to cope with, and a list of tools or resources that you're going to use, coping strategies, and then you act. Behaviour is visible. The behaviour and the person are visible, but the 3 boxes in the middle are not. And this is where we get misunderstandings. People say, oh, he's not coping, when actually he may be doing all sorts of processing and weighing up pros and cons that we just can't see. And the best we can do is listen to try and understand. Now, some patients have a very sketchy understanding. That box that says appraisal may be missing a lot of information because their prognosis is uncertain, or for other reasons like memory problems, sleep disturbance and so on. So think about the effect on the mental list of the tasks and the selection of coping strategies. Imagine a man who's got a complete high-level injury and he doesn't know this yet. He thinks he has a virus. He thinks he'll be well and back at work in a few weeks. And it's not surprising he's not interested in wheelchairs and bladder management and so on. And he has an urgent need for information, number one. And a good consultant can give honest information and keep talking as the information emerges. And this empowers the patient and the family so they can make good decisions. And knowledge is power, as I remember one of my first supervisors said to me a long time ago. Of course, once you've got the understanding, the mental list of tasks will follow in a great rush. Some are practical tasks and some emotional. We had a patient who said to me, I don't know if I will cope with this. And in his goal planning meeting later, he said, staying sane is one of my goals. Now, this is entirely appropriate. Why should we know how to cope with something entirely unknown? So I think it helps to use a goal-setting approach, and you may have come across this if you went to a rehab centre. It breaks down the uncertain future into a period of manageable activities. That's the hope anyway. I always think it's a bit like if you're driving in fog on the motorway. When we can't see at all, we're too terrified to progress. But if we can see 100 yards, slowly we can move forward. So you may be thinking, I really don't know if my career is going to be over. I really don't know what's going to happen to my relationship, children and so on. But at least I know that in this fortnight, I'm going to be doing this with my physio, this with my doctor, this with my paperwork at home, and you can focus and get on. And at the end of the 2 weeks or 4 weeks, you can look back and see, actually, I have come a little way, and you can carry on. So it's a good method to use even outside of inpatient settings, and Barbara will talk more about that. Time, of course, I mentioned, that's why you need time, is for the threat that you face to reduce and the resources that you possess to increase. As you learn, you increase your tools and your confidence in using them as well. I'm slightly out of sequence with my slides. My 14-year-old daughter put this PowerPoint together for me because I'm a technical bingo support. Number 3. This comes from lots of sources: family, friends, other patients, ex-patients, and so on, mental health professionals. Each can provide different types of support. You need to keep control and make your own choice. If you think you or someone you know is seriously depressed, then time and support may not be enough. They're important, but they might not be enough. And there is some evidence we heard yesterday that TM, like multiple sclerosis, can have a direct effect on the brain, causing depressed mood, reduced concentration and memory efficiency. Now, the person might need antidepressant medication. I'm not a doctor, so I don't prescribe that, but I encourage them to think logically and scientifically about their options and to explore it with their doctor systematically, not mess about with the dosing. They may need medication, they may need psychological therapy, or a combination often works well. And that would be aimed at restoring their mood, increasing their day-to-day functioning, because of course you have a lot to do when you're managing your bladder and managing your benefits and all the rest of it, but also to relieve the stress on the relatives. I'm sure some of you, sorry, it's hanging through, but some of you here today know that being with a person who's depressed is really hard. It's easier to be with a person with a physical disability who's not depressed than it is to be with someone who's constantly depressed, angry, irritable, and so on. So many people say, I don't want to take antidepressants, I don't want to see a shrink. We can understand that, but maybe they should think about, could it help my family? Could it help those around me? Like, at least open my mind and go on and find out more. Your GP can offer some of these, or you may prefer the voluntary or the private sector, or computerised cognitive therapy, and so on. If Psychological help is offered. You need to check the venue is accessible, because often they say it is and actually it isn't. Now, the last government put a lot of money into IAPT. Some of you may have heard of this. Improving access to psychological therapies. I'm smiling because many of us in my profession are a little bit sceptical about this. It's still new, it's still proving itself. There are great claims being made. It's about being able to get psychological help quicker and in your local area. When I worked in a mental health centre, the waiting list was typically 1 year, which is pretty hopeless, isn't it? Ridiculous. So at least waiting times are shorter. But what they've done is train up a lot of people in brief therapies, and they've got different levels. You've got level 1 practitioners who might interview over the phone, offer you some self-help or point you towards something that might help you. You've got level 2 and 3 practitioners with more skills and experience. Some will have done a full clinical training like mine, which takes years. So it's probably worth your while looking into what's available in your local area. You might have a good IAPT service, you might find a good therapist, and they might be able to point you to other useful things in your area, such as self-help groups and local resources. Now, I do like to put in a word of caution about depression. Being labelled as depressed can be helpful if it leads to the right sort of therapy or support, but it can be disempowering. People can feel, oh, I must be failing if they're saying I'm depressed. And it can have financial consequences if it's on your medical records and you're applying for life insurance and so on. Just be a bit careful and think about that. I have met people who have been described by others as depressed or very depressed, and actually on assessment I don't think they are. I think they're angry, they're grieving, and often they're in need of employment or rehousing or something like that rather than treatment. So, moving on to role models. Number 4, these are essential and available thanks to the various voluntary organisations. You need to see that disabled people can be healthy and attractive and productive if you're going to feel helpful for the future. There's the TMS, of course, here. There's the SIA link scheme, the Backup Trust mentoring scheme. These pictures come from the Backup Trust website. And of course YouTube has lots of examples of people carrying out practical tasks and talking about their condition. And there's a nice book that the Aspire charity produced called It's My Life. It's a collection of stories of people with spinal injury. I don't think any of the people in this book actually have TM, but you will see people with different levels of spinal injury and coming from different parts of the country and talking about their lives. None of them are massive sporting heroes or anything like that. They're just ordinary people who are living with and coping with their spinal injury. And Barbara in her workshop is going to talk about some examples of people with transverse myelitis, real people. And finally, I put on my list of top 5 good times. Has the person had some fun lately? Does the future look meaningful? A patient who has experienced only bed rest since the injury may feel that what is ahead is a life that one would not choose to live, and the family may share some of this fear. I actually encourage open discussion about hopelessness and thoughts about suicide. Contrary to what you might expect, it actually helps and it makes self-harm less likely. I think sometimes people are afraid that if you mention hopelessness or suicide, it will put ideas in people's heads and make it more likely to happen. Actually, feeling suicide is a very lonely place to be, and if someone else tries to listen and hold your hand in that space, it can be really helpful. So, good experiences. These are pictures from the Backup Trust website and the Spinal Injuries Association. People usually start off with things like an outing with their family, or maybe the inter-unit spinal games, something like that's been organised. But you get bigger and better things through the Backup Trust, Aspire, Disabled Flying Charities, SIA website and helpline. Of course, it doesn't have to be just disability-focused activities. It could be museums and art galleries and so on, which are more accessible than they used to be. Sometimes people want a meaningful type of experience rather than a fun experience, so you might want to think about volunteering or becoming a patient representative, sorry, I've gone too far. Or joining local groups, schools and church. You could be a school governor, you could write for a local paper, something like that. Use your strengths and be open to learning new ones. There's somebody I saw recently who can't do his old job anymore and has lost out on a lot of his social activities and has all sorts of horrendous physical complications and pressure sores and things. But he's emailed me a few times and he writes fantastically entertaining, articulate emails. And I really think we've got to get him thinking about writing or even being a comedian. A sit-down comedian. Impressive young man. Okay, I hope I've given you some new ideas about coping. I think we all share similar feelings in times of loss and stress. We can all learn from each other new methods of coping. I would welcome your comments later in the Q&A question and answer section and on the evaluation forms. So this is my farewell gesture. May your toolkit be large, varied and very well worn. And if you can read the small print, there's a little credit there to my daughter, she obviously wrote that herself.